Hello, everyone. Welcome to the Illinois Association for Healthcare Quality webinar, Using the Leapfrog Group Survey to Drive Quality Improvement. I'm Stephen Davidow, and I serve as president of the association. I'm also Director of Quality Improvement at PCPI. I wanted to go over just a few reminders about today's webinar before we introduce our speakers and get going with the presentation. I wanted to let you know that the webinar is being recorded. The recorded webinar will be posted on the association's YouTube channel, and a link will be shared in the next IAHQ newsletter, as well as the new website in 2018. When it comes to the Q&A portion of today's webinar, please use the chat for your questions, and we'll get to them as they come in. And then feel free, of course, to ask questions throughout the presentation. And then for those of you who are seeking your continuing education credit for the CPHQ, that will be emailed to you using the address provided when you registered for the webinar. Again, before I introduce our speakers, I did want to let you know that we have set a date for the upcoming annual conference, and that is May 8th, and it'll be held in Naperville at the Northern Illinois campus. And at the conference, you should know that there'll be pre-conference workshops. We'll also have a poster presentation competition, as well as keynotes and other programming and networking, and much, much more. We're in fact having our first official kickoff planning meeting on Monday, December 4th. So if for some reason you would like to be involved or submit ideas for sessions and speakers, feel free to email us at the address that I've provided on the screen. So now I want to introduce our speakers. We're very fortunate to have Missy Danforth, Vice President for Healthcare Ratings, the Leapfrog Group in Washington, D.C., who will go first, followed by Dr. Jeffrey DeLisi, who is a Senior Vice President and Chief Medical Officer with the Virginia Hospital Center. And I'm sorry, we had a slight jump on the slides. And so with that, we'll go ahead and turn things over to Missy. Thank you, everyone.
Thank you so much, David, and good afternoon, everyone. I'm sorry, thank you so much, Stephen. Good afternoon, everyone. Stephen, can you hear me okay?
Yes, I can. You're coming in just fine.
Okay, fantastic. So today I'm going to be talking a little bit about my organization, the Leapfrog Group. I'm going to give a very high-level overview of our voluntary annual hospital survey, and then talk specifically about a couple examples where hospitals have used our measures and participation in our survey for quality improvement. I do have some extra information in my deck that I'm not going to review during the presentation because we're very fortunate today to have Dr. DeLisi with us, and he's going to talk about the specific case study we actually have published on our website for Virginia Hospital Center. So first, let me start by talking a little bit about the Leapfrog Group. So for those who may not be familiar with us, we're a national not-for-profit organization. We are headquartered in Washington, D.C. I'm sorry, I am not. Stephen, I don't think I have control of the slides. Oops. Okay, there we go. We were founded by large purchasers of healthcare in 2000 in response to the 1999 IOM report. So many of our founders are companies that you've heard of, companies like GM, GE, Boeing, FedEx, and Marriott. We collect and publicly report information about the safety and quality of inpatient hospital care. So to date, we really focus specifically on inpatient hospital care. Our hospital ratings are used by all national health plans, many regional health plans, and many of the nation's largest transparency vendors, so companies like Castlight and others. Our mission is to trigger giant leaps forward in the safety, quality, and affordability of U.S. healthcare by using transparency to support informed healthcare decisions and promote high-value care. We take a regional approach to participation in our national survey. So as I mentioned, we're headquartered down here in DC, actually just a couple blocks from the White House, but we work with over 40 different organizations across the country who really act as Leapfrog on the ground. In the majority of the states, these organizations are business health groups. So for example, in the state of Illinois, we work with the Midwest Business Group on Health. The Midwest Business Group on Health and their members, on behalf of Leapfrog, actually target hospitals to participate in our survey. They do the work of actually sending out letters of invitation every year to the hospitals. They often follow up. We'll have in-person meetings, and we'll connect them to Leapfrog, our help desk, and other technical support as the hospitals might need them. And as you can see from this slide, we have what we call regional leaders in almost every state in the country. And so all the way from California, where we have Pacific Business Group on Health, to Maine, where we have the Maine Health Management Coalition. These regional leaders are really integral to the success of the Leapfrog Hospital Survey. They build relationships in their communities and really help the hospitals understand the importance of participating in the survey. Our regional leaders are also committed to using Leapfrog Hospital Survey results with their beneficiaries and their communities, both publicly and through payment. Our two major programs are the Leapfrog Hospital Survey and also the Hospital Safety Grade. I'm sure many of you are familiar with both of these programs. Today, I'm primarily going to focus on the Leapfrog Hospital Survey, which is a separate and distinct program. It's our volunteer reporting effort where hospitals actually submit data to us. But certainly, if any of you have specific questions about our Safety Grade program, I'm sure Stephen would be happy to provide you with my contact information. So as I mentioned, the Leapfrog Hospital Survey is annual. It opens every year on April 1st and closes every year on December 31st. It's also voluntary. It includes measures that matter most to healthcare purchasers and consumers. So the way that Leapfrog is a little bit unique is that we are governed entirely by healthcare purchasers. And those individuals have a great deal of input over the kinds of measures that we put on our survey, the kinds of information they say they need and want, both for their beneficiaries and, as I mentioned, to make good purchasing decisions. All of the measures on our survey are evidence-based, and where possible, I'm not sure what's going on with the slides, I apologize. Where possible, we align with other national measurement organizations, such as the Joint Commission, NHSN and CMS, as well as national registries, such as ACR and VON, and I'll give some specific examples there. Our results are publicly reported and they're free, so you can look up any hospital in the country and see the results for any of the measures on the Leapfrog Hospital Survey at this link. This is an overview of the 22 measures that we currently have on our survey. The measures are divided up into 6 different major domains. The first being inpatient care management, which includes things like ICU physician staffing, actually one of the first measures we ever put out back in 2001. 5, National Quality Forum endorsed safe practices. Leapfrog's Never Events policy, the first national policy statement of its kind that we launched in 2008. Antibiotic stewardship, which actually includes questions directly from the NHSN annual patient safety survey that we include on our survey so that the results can be publicly reported. As most of you know, CDC doesn't publicly report any information that they collect. Medication safety is another major domain. It includes 3 measures: computerized prescriber order entry, barcode medication administration, and new in 2017 is an NQF endorsed measure on medication reconciliation. In 2017, we had 17 measures focused on injuries and infections, 2 hospital-acquired condition measures looking at pressure ulcers and injuries, and then 5 infection measures. Our infection data comes directly from NHSN. Leapfrog actually has one of the largest NHSN groups in the country. We have over 2,000 hospitals that are voluntarily joined our NHSN group. This allows us to get standardized infection ratios for these 5 infections directly from NHSN, so we can use them in our survey and on our public reporting website. Hospitals don't need to self-report this data to us. Another major focus, again, because our members are purchasers and because so many of their beneficiaries are receiving maternity care focus has been a huge focus of ours. We have a number of measures of maternity care, including early elective deliveries and cesarean births. Both of these measures are from the Joint Commission. So those hospitals that are already Joint Commission certified and required to report these measures as part of that certification are able to use those same data that they're getting from their Joint Commission certified vendor and report that to Leapfrog. So no extra data collection there. However, we have some additional measures that are unique to Leapfrog, including episiotomies, bilirubin screening for newborns, DVT prophylaxis for women undergoing cesarean section, and then high-risk deliveries. For those hospitals that are a member of the Vermont-Oxford network, you can actually use those data to report to the survey. So again, no extra data collection is required. For those hospitals that are not a member of VON, we have alternative reporting opportunities. Last year, we also added a new section to the survey, pediatric care. As many of you know, because of the type of organization, the type of beneficiaries served by CMS, there's really been a lack of information available about pediatric care, which is high volume and can be extremely expensive. So we've taken the initiative to actually ensure that our survey is meaningful for freestanding pediatric facilities, but also hospitals with large pediatric units. And so we've added 2 pediatric-specific measures to the survey in 2017, CT radiation dose for pediatric patients, and the CAPS Child Hospital Survey. Now, you'll probably notice there's a number of other measures on the survey that pediatric hospitals can report on, including ICU physician staffing, safe practices, hospital-acquired infections. But we feel that it's important to really have a broader set of measures focused on pediatric care available to purchasers and consumers. And so adding these 2 measures in 2017 was really our first start in doing that. And lastly, we do have a domain focused on inpatient surgery. In 2017, the section included hospital and surgeon volume for 10 high-risk procedures, and then a set of questions focused on surgical appropriateness. Later this week, we'll actually be publishing proposed changes for the 2018 Leapfrog Hospital Survey, and there are some changes proposed to some of the measures listed on this slide. As I mentioned, our survey is voluntary, and so what's been really amazing for us is the level of participation. Nationally, and actually this number represents August ending. The survey closes, as I said, on December 31st, so we have new surveys coming in every day. But as of August 31st, we had over 1,800 hospitals voluntarily submit a 2017 Leapfrog Hospital Survey. This represents about half of the eligible hospitals. So basically, if you go back to the slide where I had the list of those regional leaders, this represents about half of the hospitals that we targeted. But also about 61% of all hospital beds, because we do get a lot of large hospitals, academic medical centers, and health systems with 100% participation, including systems like HCA, which has over 160 hospitals, all of which submit surveys to Leapfrog. We are expecting about 2,000 surveys by the end of this year. So that's an overview of who we are, a little bit of an overview of the content of the Leapfrog Hospital Survey. And now I want to spend a little bit of time sharing some examples of how hospitals have used the measures on our survey and, frankly, the targets that we set for quality improvement in their hospital. As I mentioned, the slide deck includes 3 examples, but I'm only going to really focus on 2 because Dr. Talisi is going to focus on NTSV cesarean sections. So the first example is episiotomy. Leapfrog's actually the first and only national organization that's collecting this information collecting this information from hospitals and then publicly reporting it so it can be used by both purchasers and consumers. As many of you know, AHQ has called for restricted use of episiotomy, which has been firmly linked to lower rates of peritoneal injury. Leapfrog has set a national target for this rate measure of 5%. So that means that we're expecting to see hospitals' rate of episiotomy among women who underwent vaginal delivery at 5% or lower. Our episiotomy measure is endorsed by the National Quality Forum, and it's been on our survey for many years. We actually first added it in 2012. The denominator for the measure includes the total number of vaginal deliveries during the reporting period. We use a 12-month reporting period, with cases of obstructed labor due to, and we exclude cases of shoulder dystocia. So it's vaginal deliveries minus those cases with a documented instance of shoulder dystocia. The numerator is the number of mothers included in the denominator where an episiotomy was performed, and we use ICD-10 codes to identify these procedures. This table shows the progress that we've seen across the nation in reducing rates of episiotomy. As you can see, in 2012, when we first added this measure to the survey, we had fewer than 900 hospitals reporting at that time. Our target rate for all hospitals was 12%. And as you can see, the average rate was actually above that. So the national average in 2012 was about 13%. Our average was 12%. And we had less than 50% of hospitals fully meeting our standard. So only 44% of hospitals were able to meet our target rate of 12% or lower. You can see in 2013 and 2014, we're seeing a couple things. First is we're seeing an increase in the number of hospitals reporting on the measure. Next, we're seeing an increase in the number of hospitals able to meet our target. You can see that in 2014, 66% of hospitals are able to have a episiotomy rate of 12% or lower. And in fact, the national average has gone from 13% to 11.3%. This actually resulted in Leapfrog's national expert panel. We have an expert panel that oversees every section of our survey. So the maternity care expert panel actually reviewed 3 years worth of data and made the decision in 2015 that we would actually reduce the target rate from 12% to 5%. And you can see a couple of impacts of that. So first, we're continuing to see that increase in participation, but also you can see that decrease in the percentage of hospitals able to meet that target the first year when we changed it. But what I'm really happy to report is if you can look all the way over to 2017, and this is data as of July 31st, again, the survey is still open, what you can see is that we've actually bounced back. And so now we're back up to about 44% of hospitals able to fully meet the standard. That means of having a rate of 5% or less. And nationally, what we've done is drive down the average rate from 13% to 7.9%. This is just a graph that shows that same data. But the case study I wanted to highlight, it comes from Texas Children's Hospital Pavilion for Women in Houston, Texas. They reduced their episiotomy rate from 9% to 4.4%. They actually published a paper in a peer-reviewed journal that talked about their journey to go from 9% to 4.4%. And in that paper, what they highlighted as their 3 keys to success were the following. First was having a stretch goal. They talked specifically about Leapfrog changing our target from 12% to 5% and how that really motivated them to do the hard work to reduce their episiotomy rate. The second thing they talked about was having professional society guidelines that were available to support the desired practice. So what they were able to do with their OBs is that they were actually able to point to specific published professional society guidelines and reference them in terms of supporting this desired outcome. And just as a point of fact, those guidelines actually have been published for several years before Leapfrog put this measure on our survey. And lastly, were physicians knowing that their performance was being monitored. And this is really important, we think, because it really highlights the importance of transparency. And so, by Leapfrog having this measure on our survey and bringing it really this national attention, creating this stretch goal with the help of our national expert panel, so reducing the national target from 12% to 5%, having these guidelines published by ACOG, then also they were taking their physicians' rates and making them public so any physician could see their peers' rates on an ongoing basis. These are the 3 things that really help them drive down their overall hospital-wide rate. This is just a screenshot of the abstract from their paper in case anyone wants to access a copy. It is behind a paywall. It's titled An Initiative to Reduce the Episiotomy Rate, Association of Feedback, and the Hawthorne Effect with Leapfrog's Goals. And I would highly recommend you reference this as it's just a fantastic example of the impact that Leapfrog can have in helping hospitals attain quality improvement goals. I'm just going to briefly describe our NTSV C-section measure, but again, Dr. DeLisi is here to talk about their specific experience. So we have the Joint Commission's NTSV C-section measure on our survey. And so it's cesarean deliveries for first-time mothers delivering a single baby at term in the vertex position. Our national target is 23.9%. That target actually aligns with the proposed target published by Healthy People 2020. As many of you know, the measure is endorsed by the National Quality Forum, but I think more importantly is its use in the Joint Commission's perinatal care measure set. Leapfrog put this on our survey in 2014, but we actually didn't start publicly reporting the results until 2015. Typically, when we put a measure on our survey, we don't publicly report the results for the first year. We like to give hospitals some experience with data collection and also some time to put processes and protocols in place. So for example, for those hospitals that are Joint Commission accredited, they probably were collecting data for this measure and needed that extra time to really put some data collection protocols in place. This is not, but we did start publicly reporting in 2015. So 2017 is our third year of having data on this measure. The denominator for the measure, again, are nulliparous patients, so women delivering their first baby, that delivered a live term singleton newborn in the vertex presentation, and there are some exclusions. The numerator are the total number of patients included in the denominator with a cesarean birth. I will tell you that nationally, the average rate of C-sections, and this is from 2016, was much higher than our target rate of 23.9%. And we are really not seeing progress as quickly as we have in some of our other maternity care measures in terms of reducing that rate. But again, it is still early. This is only our third year. I am going to move on, however, and talk about early elective deliveries. Leapfrog was the first national organization to actually collect this data and publicly report it. So the Joint Commission obviously has this measure as part of their perinatal care measure set, but Leapfrog was actually the first to put it out, collect the information, and actually publish rates of early elective deliveries. We were actually several years ahead of CMS. So many of you know that now this measure is included in the CMS Inpatient Quality Reporting Program, but Leapfrog's use of this measure and making these rates available precedes that of CMS. Our target rate for this particular measure is 5%. And you can see from this slide, we've seen significant reduction since we first started publicly reporting in 2010. So hospitals' rates have actually declined from 17%, and that's the national average in 2010, to less than 2% in 2016. There are several reasons for this. So a couple of things. First is that, again, the behavior that we were looking for, the behavior change we were looking for to reach this outcome of reduced rates of early elective deliveries was supported by clinical guidelines. So there was evidence-based clinical guidelines that hospitals could point their physicians to. The second piece, frankly, is measurement and transparency, and that's where Leapfrog, I think, has played an important role, and now CMS really supports that as well. But another piece is the collaborative efforts with multiple stakeholders. The March of Dimes, the American Hospital Association, Catalyst for Payment Reform, and others really played a huge role in both consumer education, support for hospitals and providers, but also using this particular measure in payment. All of these things really help to reduce the rate and reduce the rate quickly over time. Now before I turn it over to Dr. DeLisi, want to just share with you a couple examples of how other types of organizations use Leapfrog data to drive quality improvement. So obviously it's extremely important to Leapfrog's mission that hospitals are able to use this information to improve care. But as I just pointed out in my last example, what helps is when health plans employers and purchaser groups, and consumer groups also get involved. And again, the best example of that is what we saw with early elective deliveries. So I did want to share with you some examples of how these other types of organizations are using Leapfrog. So the first is that there are health plans that use Leapfrog hospital survey results in value-based purchasing. This is a screenshot from a press release where CarePoint actually awarded $350,000 to hospitals for safety achievements. If you read the article to the right of the screenshot, you can see that those achievements were entirely based on performance on the Leapfrog hospital survey. So in some states, hospitals actually get extra financial incentives for participating in the survey and doing well on those measures. In addition, though, and I think importantly, many health plans, including all the national health plans, but also many statewide and regional health plans, are using Leapfrog for member education. So the left side of this slide is actually a screenshot from a health plan member tool, where you can see that Leapfrog hospital survey results are displayed. The right side is actually a screenshot from a Twitter post made by Aetna, directing folks to take a look at our patient safety ratings. However, our own employers and purchasers, including those business health coalitions I showed you on one of those early slides, as well as the purchasers like FedEx, Boeing, and others that work directly with Leapfrog and participate on Leapfrog's board of directors, they're very active as well in using Leapfrog hospital survey results to help drive quality improvement. They educate their employees on choosing a hospital by making our survey results available to their employees during open enrollment periods, and by encouraging their vendors, whether it be Castlight or another transparency vendor or a health plan, to make Leapfrog survey results available in the health plan or transparency vendor's member tools. They leverage their purchasing power to structure value-based purchasing and contracting agreements with health plans. They use Leapfrog hospital survey and benefits design, sometimes through tiering or waiving deductibles for high-performing hospitals. They also encourage transparency and accountabilities in hospitals in their community. And again, I'll go back to that regional leader example, where many of those folks at those organizations are going out to hospitals, meeting with CEOs, taking tours, and sitting down and talking about the importance of participating in the survey. This is just a couple other examples of how our members are using our survey results in their employee education. This is actually a couple of screenshots from two different regional leaders. The left side is Healthcare 21, which is a business coalition that works with us in Tennessee. And the right side is the South Carolina Business Coalition on Health. Both of these organizations produce extensive annual reports that include Leapfrog hospital survey results. The reports are shared with all of their employer purchaser members and many of their beneficiaries. And as I mentioned, consumer groups also play a role. Most recently, Consumer Reports has started using Leapfrog C-section data on its website and on its and many of its consumer-based blogs and articles. This got a tremendous amount of attention. Many consumers are coming to know Consumer Reports as a place they can go to for not just information on cars and toasters and washing machines, but also healthcare ratings. And so by adopting Leapfrog's cesarean rating into their website and featuring it in a series of articles on their website, it brought a tremendous amount of attention to this information. And lastly, this is just a screenshot from our website. So as I mentioned, our survey results are free. You can log on, you can visit our website today and look up results for any hospital in the country. We use cell phone bar icons to display a hospital's performance, where 4 cell phone bars means fully meets the standard. That's our highest rating on any individual measure. 3 bars is substantial progress, 2 bars is some progress, and 1 bar is willing to report. Those hospitals that haven't met our target but are at least being transparent do earn some partial credit for that. Hospitals that decline to respond to our survey are publicly reported as declined to respond. And as I mentioned, our survey is still open until December 31st, so there's about a month left. If any of you on the call today have any questions about the survey, as I mentioned, what I'll do is actually I'll send a contact for our survey help desk, and they can answer any questions you might have. So I'm going to stop there and actually turn it over to Dr. DeLisi so he can talk about the very impressive case study that's come out of Virginia Hospital Center.
Great, thanks, Missy. Can everyone hear me on the line?
I can.
Okay, good. All right, just making sure.
We can hear you. Yep, you're good.
Great. Thanks, Missy. It's an honor to be invited here to participate in the webinar today. So just a little bit about us real quickly. We're Virginia Hospital Center we are an independent hospital. We're licensed for 394 beds. We're in Arlington, Virginia, so we're just across the river from Washington, D.C., where Missy and the Leapfrog group are located. We have been in existence since about 1940. We do about 24,000 inpatient admissions a year. And about we've averaged somewhere between 4,000 and 6,000 deliveries a year the last several years. So the OB business, so to speak, is a big part of our mix. So our story sort of dates back to 2014. And, you know, initially, what I think one of the things that really grabbed our attention was the focus of the Leapfrog group started putting on C-section rates. And I think that was picked up by area media companies. And in fact, one of the local news stations did a kind of evening news report on C-section rates in the area. And it turns out that several of the hospitals in our area, we were all in the 10 worst in the entire country, which is never something you want to see on the evening news as a leader of a hospital. I think it was Reader's Digest was also putting a real focus on this, and they've published, I think, a yearly report on C-section rates as well, kind of who are the highest C-section rates in the country, what are the biggest hospitals with the highest C-section rates. And again, we were just, quite frankly, one of the worst back in 2014. So we knew the Leapfrog group was about to start presenting it publicly. We sort of got together as a leadership team and tried to figure out what we could do to move the needle. And one of the things that, you know, it's been a good experience for us to go through a Virginia Hospital Center. And I think it's helped me to sort of visualize what it takes to be successful in these kind of endeavors, is a phrase I like to call vertical integration of accountability. And what that sort of jargon of word means to me is, you know, the lowering our C-section rate became one of the board's objectives for our chief executive officer. And so since it was on the CEO's objective list, it became one of my objectives as the chief medical officer. And since it became one of my objectives, it became all of quality's objectives, because quality was reporting up to me. It also became the objectives of the chief nursing officer, the nurse leads over OB. And so we really took that goal and spread it throughout the organization. At the same time, we took one of our OB's physicians in the hospital who we thought really could be a champion for this, and we made him the medical director of labor and delivery. And held him accountable to helping us to lower the rate as well. So, you know, once we put that into place, that was sort of step one, and I think that really helped us to focus. And the medical director of OB set up kind of monthly meetings with other obstetricians in the department. And they got together and they literally looked at every single C-section to see, was it avoidable? Could we have done something differently? You know, really trying to get some idea of the trends. There was a lot of pushback. We are fortunate that I think we're in a fairly affluent area. And we've got a lot of very highly educated kind of working mothers that deliver babies here. And so a lot of them quite literally were sort of saying, I want to have my baby on November 30th. And the OBs were more than happy to sort of coordinate that and give them the delivery date that they wanted. And so that was leading to a lot of kind of early elective deliveries and then subsequent C-sections as well, scheduled C-sections. So we were able to get rid of our early elective delivery rate and take that down to zero pretty quickly. That was sort of win number one. But really changing the messaging to our patients, I think, was one of the biggest hurdles that we needed to get our obstetricians bought in on and kind of moving forward with. And I'll be, be sort of direct here. I think that the most significant thing that we did to change behavior, and very similar to what Missy just showed you with the hospital with the episiotomy rates, was, at some point we just said, we're going to display the C-section rate by doctor and post it in the OB lounge. So we made it very transparent by doctor and by group. And I think whenever we do something like that, there's always people that are nervous. Our medical director was certainly nervous as to what would happen and what would people talk to him anymore. And I think, as healthcare leaders, we always get a little nervous about being transparent. But I think usually once we're transparent, we can move the needle. And I think a lot of that is just doctors in general don't want to be bad. They want to be high performers. They want to look good. Nobody wants to be the worst. They're competitive people by nature because they went to medical school, and you weren't at the bottom of your college class if you got into medical school. So once you're transparent like that, people tend to change behavior pretty quickly. So we went from a rate that was sort of in the mid to upper 30s in 2014. In 2015, we actually got it down to 27%. And then last year, we were able to take it all the way down to under that Leapfrog goal of 23.9%. I think we were around 22% last year, 22.5%. And this year, we're right around 21%. So we continue to push that number down. But, again, we use that Leapfrog metric as sort of a goal. We really look at the Leapfrog group as a real leader in patient in transparency to patients. We think the survey is critical. We think that the safety grade is a very important sort of data point that we need to continue to focus on, make sure that we continue to get A's on. And so we look at what the Leapfrog group is doing and what sort of benchmarks they're expecting of us. I think they're well thought out, and when you think about what they're pushing, their safety goals that they are expecting of hospitals are things that are, what I like to say, just in the best interest of the patient. A lot of women, and my wife included, my wife did not have C-sections, but she looked at some of our family members that did have C-sections, and she thought their recoveries were easier. And what I've told her, and I think we've been able to message, is that, look, C-sections are good for certain patients. They're needed and they save lives when they're appropriate, but you don't want to do unnecessary C-sections, because another word for a C-section is a surgery. And surgery comes with risks and complications and potential infections and downstream potential complications of that, years in the future. So you can prevent them. It's a great thing for patients. So I think this is another just great example of the Leapfrog group, putting the focus on the patient and helping to drive performance around the country. So we're thankful that they helped to shine the light on this metric and others. And it's something we really took to heart and tried to get better on. So I'll turn it back over, and I'm happy to entertain any questions if anybody on the call has them.
Okay. Please, this is Stephen Davido. To our attendees, please type in any questions you have for Missy or for Dr. DeLisi, and we'll address them during the Q&A. So while we wait for some of the questions to come in on the chat, well, I'm going ahead here on the slides, I'm sorry. What would be, if you were to summarize, Dr. DeLisi, in terms of kind of key tips to encourage people to use the survey to drive improvement? I mean, you've talked on it and you've given your story, but you mentioned posting results in the doctor's lounge. What are some of the other kind of like 3 things that some of the folks that are on the line should be thinking about? Because I believe we have some hospitals represented who are not participating right now, and folks are a little apprehensive to do so. And I think you spoke to that. But it would be helpful, I think, to kind of like the 3 things to tell people how this can help them drive improvement in their organizations.
Well, I think if you know you're going to report it out, you're going to do your darndest to get better at it, right? So we know we're going to report out that Leapfrog survey every year, and so we look at what the survey entails, and we, try to maximize our performance in those areas, or put in, a lot of the Leapfrog survey isn't necessarily a rate of something, but have you put the safety process in place? Are you reporting on safety events up to your board of directors? So we've taken the lead on some of those things, and I think they've been great. I also think, much more transparent with our board of directors now than we've ever been. A lot of that is a result of some of the bullet points that are within the Leapfrog survey. So we're really proud. We think we're a safer hospital because we've told ourselves we're gonna do the survey. I'll say one. It doesn't quite answer the three things about the survey, but maybe just one other quick anecdote. When I've been CMO now for about 6 years, and when I first took over, or first came into this role, my previous quality leader was not for filling out the survey, and just said it's going to take an inordinate amount of time. We'll need a full-time employee to fill out the survey. And that was certainly not true, because, even 3 or 4 years ago, I think the first year I got the information myself and filled it out. So I was able to do it just in my role. So, really, I don't think it takes a ton of time to do the survey. It is a bit of a time commitment, and the CPOE flight simulator does take our IT team. They spend a good half day to a day getting that done. But I think the three takeaways for me are: number one, it's going to help you drive performance, because if you know you're going to fill out the survey, you're going to be paying attention to what's on the survey, and I think what's on the survey translates to good, safe care. Secondly, if you fill the survey out and you do well, that's something that is meaningful to payers and to other consumers of healthcare. We certainly hear there's a very positive reaction when patients see that we think that it's really important to our value story, which is kind of high quality at a good cost. So having that and showing people that we're a safe hospital is important. And maybe third, and it's kind of related to all of those things, I would just say, again, you look at the survey and you look at what they're asking, you look at what they're measuring. These are things that are just in the best interest of the patient. I know that sounds simple, but I think when you think about healthcare from the perspective of the patient, it becomes a lot easier to make decisions. So if you look at the metrics, you think about are these things important to patients? It's hard to argue against any of them. And kind of sort of holistically, if you look at healthcare in general and say, is it in the best interest of patient to have access to hospital performance? I think the answer is yes. So I think I think it's the right thing to do to fill the survey out.
Super. Thank you for that excellent answer. One of our attendees has got a question, or actually two questions, for Missy. She's asking, what were the performance time frames for the reporting periods, one, and two, what, if any, impact did you observe on the findings that may be due to conversion from ICD-9 to ICD-10?
Yeah, can you just ask her to specify which of the measures she's referring to? I just want to make sure I can accurately answer the question.
Okay, we'll wait for a response.
And then also, I'll bring up that slide too, so everyone can see it.
Oh, I think I'll give you control back, but I'm waiting for a response on that. While we're waiting for some more specifics, Missy, I wondered if you had any other tips or things you wanted to add to Dr. DeLisi's comments that he just had on kind of the tips for folks.
No, I mean, I think he had some great points. One thing I would just recommend is, we have a fantastic help desk here at Leapfrog that is really dedicated to providing hospitals with technical support, answering any questions they might have about the measures, the specifications, the reporting periods, the deadlines, and even just navigating our online survey tool. So I would highly recommend utilizing our help desk. I talk to hospitals and groups of hospitals and hospital associations all over the country all year long. And one sort of consistent theme is the overwhelmingly positive feedback that I get about our help desk and our help desk team here. We answer questions, typically the day that you submit the question, but at the very latest within 24 hours. I think that it can be really helpful making sure that hospitals aren't wasting a lot of time and resources trying to figure something out that we can help you answer, maybe in 5 minutes. So just to definitely utilize our help desk. And did you get a response about the measure?
The response was that it just says based on the graphs that were presented on the earlier slides.
Okay, so let's go to like the episiotomy graph.
Okay. Thank you. So. This one? I'm sorry.
Yeah, that's perfect. Actually, let's go one above it to the table. So for the Leapfrog Hospital survey, we actually have 2 reporting periods for every survey cycle. So not to get too in the weeds, but I just want to make sure I answer the question accurately. So as I mentioned, the survey is open every year from April 1st to December 31st. Hospitals that submit a survey prior to September 1st of any given survey year are asked to report on the previous calendar year. So let's take this year, for example. If my hospital submitted a survey prior to September 1st, 2017, I would report on calendar year 2016. If my hospital submits a survey for the first time after September 1st, or if I just want to resubmit my survey because I've improved on the measure, we actually move our reporting period up 6 months. So I'd report on the last 2 quarters of 2016 and the first 2 quarters of 2017. One of the unique things about Leapfrogs I didn't mention is our reporting periods are really different than CMS. We try to make them as current as possible. So we don't want to be unrealistic. So we know it takes time for hospitals to actually get the data or get the reports back from their vendors. But we do try to make it as current as possible. So that means in 2017, hospitals for many of our measures are actually reporting on at least 2 quarters of 2017. So I don't think that the improvements are related necessarily to the reporting period. I think what we see consistently, regardless of the reporting period, is that hospitals are improving over time. In terms of the transition from ICD-9 to ICD-10, that's a great question. We actually did some work with the measure developers. So for early elective deliveries and NTSB sections, we consulted the Joint Commission. And for the episiotomy measure, we actually did some internal analysis, but also because it's an NQF endorsed measure, the measure developer has to produce some statistics about the transition from ICD-9 and ICD-10. And what we're seeing is the measure specifications for all of the measures are generally capturing the same thing. Now, because of the Joint Commission's measure specifications, once in a while they're add an exclusion or drop an exclusion. That really is only accounting for very minimal variation in the rates we're seeing over time. And the same is true for this episiotomy measure, where the code capturing the episiotomies really hasn't significantly changed. It's not like the code includes many more types of procedures or fewer types of procedures, particularly for episiotomy. And so we are not attributing any of the improvement we're seeing in either changes in the reporting period per se. I think it's more improvements over time, or in the transition from ICD-9 to ICD-10.
Okay. Thank you very much. Let's see. Before we, let me see if I got another question on the chat. I did. While we wait for a couple more questions to come in on the chat. Missy, I wanted to ask you, and I think you've touched on it by partly being part of this presentation and just discussing how Leapfrog Group works with hospitals, and Dr. DeLisi, and you may weigh in on this, but I think you also touched on it. But I think for many that don't participate, there's a certain amount of fear about the idea of participating and working with the Leapfrog Group. How should they think about working with you?
Yeah, I mean, I think the hesitation is really coming from 2 places. both of which Dr. DeLisi spoke to. So the first is the burden, right? So what are the resources? And the second is the transparency, right? So what if we do this and we just frankly look horrible? And so, what I can say is, over time, we really worked hard in reducing the burden. I think the survey is fairly manageable. I mean, we have critical access hospitals that submit a survey every year. These are 25-bed hospitals. In terms of the transparency, I think that it can be hard. So as Dr. DeLisi mentioned in his example, the first time their C-section rate was reported, they were one of the worst in the country. But that motivated them to become one of the best in the country. And now they're a case study on our website. So I think that the transparency can be tough, but I think that it can really help in driving improvement. And what I'll add is that we actually do quite a bit of consumer testing. We typically do focus groups where we talk to consumers about the icons that we're using and the display of our results and all kinds of different things. And consistently what they tell us is that they are much less concerned about a hospital with poor performance. They're much more concerned about a hospital reported as declined to respond. For the hospital whose results they can see, and they may be bad, but they at least have the sense that they're being honest and they're probably working on it. They have a tremendous capacity to give folks the benefit of the doubt. For those that aren't reporting at all, they assume that the hospital is not reporting because they have something to hide, and that they're doing very bad. And so, I think that hopefully is just one thing to take into consideration, is that from a consumer perspective, they'd much rather see something than nothing. And again, our help desk is there to help, but Dr. DeLisi might have more to add.
No, I don't have too much more to add to that. I mean, I think I'll echo what she said about the help desk, because we've needed them from time to time, and they've always been very responsive and kind of gotten right back to us. So, it's been easy to do that. And I totally agree. I think, again, maybe it's the consumer reports that I said Reader's Digest. I think it's actually consumer reports. And Missy did mention that they do the yearly article on the C-section rate. But it looks really bad for some of these larger hospitals when they say, consumer reports somebody else says does not report or doesn't wish to report. And I think that always raises more questions than if you're at least reporting. And, if you're not getting better than something, tell people what your action plan is. Or if you're not as good as you want to be on something, tell people what your action plan is. I think, I think people understand that, and it's better than being not transparent.
Any other questions, Stephen?
I apologize, I was on mute. We have another question. It says Leapfrog weights for the different measures. Is it true that there is a different weight for safety, for the safety score versus VBP? Please advise.
Yep. So this must be someone that's very familiar with Leapfrog. So the third program that Leapfrog administers that I didn't go into detail about at all is a value-based purchasing platform, or VBP. A value-based purchasing platform is basically a pay-for-performance program that health plans can license. It's a way to use the Leapfrog hospital survey results in payment. It actually takes all the measures on the survey and assigns a score from 0 to 100. And then we actually calculate individual measure scores and domain scores. Some of the measures used in the value-based purchasing platform, because it's those measures that are on the Leapfrog Hospital Survey, for example, CPOE, ICU physician staffing, are also used in our hospital safety grade program, and the weights and the methodologies are very different. They're actually completely different. So if you have any detailed questions about the differences between the weighting or the scoring methodology for the value-based purchasing platform versus the hospital safety grade, please go ahead and submit a help desk ticket to helpdesk@leapfroggroup.org, and we'll send you some information in writing right away.
Great. We have another question for Dr. DeLisi. They're asking if you could speak in more detail about the vertical integration at your organization and how involved was the board in holding mid and senior level management accountable? How could we avoid the Leapfrog group survey being dismissed by staff and clinicians as a survey and just a quality project, and quotes around quality project?
So the questions around how do you avoid clinicians from blowing it off?
Yeah, staff and clinicians viewing it as a survey and just a quality project, basically, yeah, blowing it off. And the first part of the question was, how involved was your board in holding mid and senior level management accountable?
Well, so the board holds senior management accountable. And, you know, again, the way it works is every year our board gets together with, you know, our CEO speaks with us, the management team, and then in conjunction with the board, there comes up a list of sort of CEO objectives that, you know, he has to meet every year. And those sort of form the basis of, you know, what become our accountability standards at the sort of vice president level, sort of within the C-suite. So, you know, we don't make, and our accountability standards aren't just sort of like fill out the survey. It's what are the targeted goals? So, you know, get the C-section rate below 24% is what specifically was in the goal. But I think to get buy-in across the organization, the key is that, you know, lots of other people get that exact same goal. So the C-section rate being less than 24% wasn't just a goal for, you know, it was a goal that the board came up with that they were holding the CEO accountable for. And so then, you know, I'm part of that. The CNO's part of it. The nursing leaders in women and infants are part of it. Quality is part of it. And then I do think it is key to get, I think it was key to our success to have physician champions, and especially getting that medical director who was accountable to it, I think really helped as well. Because I think that's part of the way you change it from being, oh, it's just a survey or something like that. If you can have a physician champion that can speak to the why is this an important goal? Why is it a patient safety issue? You're bound to be more successful.
That's great. Thank you very much. Well, I don't see any more questions in the chat. I think we've covered this topic very well. I really appreciate our speakers, Missy Danforth and Dr. Jeffrey DeLisi, for participating today and sharing their knowledge and experience on this topic. I think also I want to share my appreciation for our attendees to participate today. Before I close out the webinar, I did want to note that we are going to be sharing the slides in a recording within the next 10 business days, so that you can look for that, and we'll publicize that in our e-newsletter. So if you're a member of the association, you'll get information about that. You can also follow up with me. We'll post it in our LinkedIn site, and you can also sign up for our newsletter. And then you can also email the association, and we'll get some things out. And here's my email address. And so I thank you all for participating today, and I wish you well. So thanks, everyone. Have a great rest of your day, and happy holidays a little early. Take care, everyone. We'll now shut down the webinar. Take care.
Thanks.